All right, now we're going to get into coronary artery disease. Do you think in cardio, when we went through that little outline of Med-Surg, what were some of the biggest topics? Heart failure, coronary artery disease. Why do you think these are such big topics? And that's just one section of Med-Surg, right? We covered a little bit of renal, but in one section. Why? Because they're common. You think coronary artery disease is common? Those of you that are in the course or watch the on demand, how much time do I spend on heart failure and coronary artery disease? A lot, right? So it shows you how important these are. So again, who are we going to see first? Prioritization. Let's find one of asked graph. A nurse is caring for 4 patients with CAD. Let's see what's going on here. A patient who had a coronary bypass graft 2 days ago with a temperature of 100.3 and mild chest drainage. 100.3. Wait a minute. 100.4, I'd be a little bit scared. Yeah. Expected drainage. Any purulent drainage? No, no purulent discharge, no. 100.3, I'm not really too concerned, okay, but we haven't made a decision yet. A patient with stable angina reporting sharp chest pain for 2 hours, but is relieved with nitroglycerin. Between the two, which one I'm going with? I'm going to go with 3/4 as well, too, because this one is expected. Why do they have a temperature? Somebody tell me. And what blood cells are elevated? It's post-op stress, right? It's stress. And what white blood cells are going to be elevated? Neutrophils. Real life, right? I teach you all this. Neutrophils are elevated. Does it indicate infection? It could, but why is it not? Because our temperature is not 100.4 or above. So there you go. No purulent discharge. So again, so I'm concerned about this, but it is relieved with nitroglycerin, but I still choose 3/4. Let's compare 2 to 3. A patient scheduled for coronary angiogram today reporting anxiety about the procedure. Well, if I'm about to have a coronary angiogram, anxiety is probably going to be there. I mean, it's just part of the process, right? So because we do give them anti-anxiolytics when they go into a coronary angiogram. And those of you that don't know, we talk about the difference between a PCI versus coronary angiogram, right? We talk about all these different things, stent. These are all different things, and people tend to kind of make them into one term. But you should know the difference between all of those. And if you don't know the difference, then you should definitely be watching our on-demand. Coronary angiogram today, anxiety, whatever. We're down to 50-50. A patient reporting new onset chest pain radiating to the left arm and jaw and not relieved by rest or nitroglycerin. All right, so what do we have going on here? What has this coronary artery disease led to? It's led to an MI. Yeah, we're worried about a myocardial infarction, right? Because at this point, that chest pain that's happening is not being relieved at all, even though I'm vasodilating with nitroglycerin, even though I'm resting, it's not being alleviated, period. So that blockage is now something of concern. We're going to take them to the CAD lab. And we talk about that in depth, right? Those are my students. We talk about the CAD lab, we talk about PCI, we talk about stents, we talk about anticoagulants or antiplatelets, all that stuff. You need to know all that stuff. Talk about Med-Surg, you need to know it in depth. All right, let's continue on with a little bit more cardio. Which patient requires immediate attention? So a nurse is reviewing telemetry readings and symptoms for 4 patients. So again, who do we see first? Initial priority, urgent, most concerning. So we've got a patient post-MI with shortness of breath and mild pedal edema, or a patient with CAD experiencing chest pain and a new STEMI, ST segment elevation on ECG. So what are we worried about here? Post-MI, shortness of breath, mild pedal edema, okay. Or somebody that's having a new ST segment elevation. We're worried about them having an MI. Yeah, again, we're talking about coronary artery disease. So we've got to take a look at this. A patient with chronic stable angina reporting a burning sensation in the chest while laying down. Wait a minute. Okay, they got stable angina. They got burning sensation in the chest while laying down. Why am I choosing 3/2? What am I thinking 2 is? It's a differential diagnosis because I could throw this into a bow tie in a heartbeat, into a case study in a heartbeat. It's probably GERD. Yeah, it's probably GERD. It's probably acid reflux or GERD, one of the two, right? But that new SC segment elevation, I'm freaking out about, right? And now we're down to 50-50, a patient with a history of CAD experiencing new onset dizziness, palpitations, with an ECG showing frequent premature ventricular contractions, or PVCs. Are PVCs harmful? We don't really talk about that too much. No, they're really not. It just means that the lower chamber is beating before. That's it. But it's typically not dangerous. So between the two, I'm concerned about the person that's having an MI. An MI, right? So again, there you go. Nurse Brittany, are you able to do? I'm gonna do the EKG ones. I really want to show people the EKG ones, and then are you able to do a little bit of delegation towards the end?
Sure. Yeah.
Okay. So another big topic is obviously delegation. I want to get to that, but I want to show EKGs because people don't really understand EKGs very well. But those of you that have taken the course, how well do you know EKGs now? Like it's really not that hard. It really isn't that hard. So if you're afraid of EKGs, don't be too intimidated. It's really not that bad. It's really not that bad. All right. So again, what's the nurse's priority action? A 65-year-old male is brought to the emergency department by paramedics after collapsing at home. Upon arrival, he is unresponsive, pulseless, and not breathing. What is a big word here? Of everything that you see here, even though no pulse, there you go. Which means that, are we going to shock them? Is that going to do anything? No. What are we going to do first? Good. Already you're thinking ahead, right? So let's see. Insert oropharyngeal airway and provide bad mask ventilation, or administer epi. Between the two, let's try to protect the airway, right? Then begin cardiopulmonary resuscitation, or CPR, and prepare to defib. So once I get that CPR going, once I get a beat, guess what I'm going to do? I'm going to shock them. I'm going to defib. In defibrillation, is it synchronized or unsynchronized? Tell me. Unsynchronized. Good. So in this situation, can I shock them if they're pulseless? No, it's not going to do anything. But if I start CPR and I'm able to get a beat again, and even if they're in VFib, boom, I can shock them. Unsynchronize and shock them. So yeah, I would choose CPR. And then amiodarone over CPR, obviously, we're going to go with CPR. What are the 3A drugs that we need to know in EKGs? Somebody tell me the three drugs. Amiodarone, atropine, and adenosine. If you don't know the difference between those, you're going to be in trouble. So make sure you know them. Not only that, with adenosine and atropine, do we have specific dosages and administration, med-ad? Yes, we do. So make sure you know those. Again, it's in the EKG lecture. It's in the EKG lecture. So make sure you watch that. So what I wanted to show here, it was an easier question, right? Pulseless CPR. The point of me showing this question was not to show that it's an easy question. It was to show the actual strip. Because when we do actually shock them, we look for what wave? When we synchronize, we look for what wave? An R wave. In any other dysrhythmia, SVT, VTAC, AFib, A-flutter, do we have an R wave? We always have an R wave. In this situation, do you see any R wave? No. So if you're going to synchronize and try to shock them, you're not going to find an R wave. So you're going to be sitting there waiting, and they're going to die. So who cares about synchronization? Unsynchronize and just shock them. That's it, right? So that's what the reason why I want to show you that one. And I'm going to do AFib, and then I think Nurse Brittany will probably be able to get into maybe a question, maybe two, into delegation as well too. All right, which action should the nurse take first? Again, this is more so to teach you a little bit about EKGs because that is a big topic in Med-Surg under cardio. A 72-year-old female with a history of AFib and hypertension presents to the clinic for routine checkup, history. Current medications include warfarin. Why? That AFib is going to lead to stasis. We're worried about clots, right? We talk about that. Should you know the difference between warfarin and heparin? Absolutely. If you don't know it like inside out, we're in trouble. Do you think you should know your beta blockers? Inside out. Absolutely. Bridging. Good job. Lisinopril, ACE inhibitors? Absolutely. These are all high yield pharm. Med-Surg, cardio, pharm. Huge, huge. Reports occasional palpitations and dizziness. Nurse notes an irregular heart rate of 110 beats per minute and a blood pressure of 140/85, which is the following actions you would take first. Educate them on caffeine intake. Did this person say they're drinking 10 cups of coffee a day? I don't remember that. Or obtain an EKG. So we'll get rid of this because there's no indication of caffeine. Check their INR. Well, they're on warfarin, but is that really of concern? Not really. No. So of course we're going to check. Again, easier question, but the point is that atrial fibrillation, what part of the heart is giving me an issue? The atrium, straight up, it's the atrium. Between your EKG, you've got what is your normal EKG look like? A PQRST, PQRST. What part is the atrium? The P, which means that where I'm supposed to see a P, am I seeing a P? No. What's happening during that P? It's fibrillating. It's quivering. So I'm telling you what's happening. People are like, well, how am I going to know what's happening? Well, look for where the P wave should be and look for this, because this is what's happening during that P wave. That AV node, that atrioventricular node, is waiting for an impulse from the atrium, but it's not going to happen. So you think the AV node is going to let the ventricle sit there and just not beat? No, the ventricle is going to beat. It's going to do its own thing, and it's going to do it whenever it wants. Maybe it'll wait for a long time. Maybe it won't. So you get that irregular heart rate. So we've got a fib. Be able to identify. EKGs are identification. Again, where you should see a P wave, all we're seeing is that quivering, that fibrillation. Am I going to wait maybe a little bit here, a little bit less here, way less here, a little bit longer here? Maybe I'll wait a long time here, but I'm still going to beat. My AV node is still going to beat. My ventricle is still going to go and give my QRST. I just don't got a P, right? So that's EKGs. Nurse Brittany, are you able to do some delegation real quick?
Yeah, definitely.
Absolutely.
I don't know if you might have to write, Dr.
I'll write for you. You're good.
Okay. Okay, so let's start. So let's see. So we have a select all that apply question. So which tasks can be appropriately delegated to the LPN? So we're looking at what the LPN is able to do here. So, why did my screen turn black? Oh, there we go. A registered nurse is delegating tasks to a licensed practical nurse, or LPN, and unlicensed assistive personnel, a UAP, on a medical surgical unit. Again, which tasks can be appropriately delegated to the LPN? And it's a select all that apply. So let's start from the bottom and go through all the answers. Let's see what you guys think first. So starting an IV line for a patient requiring fluids. Do we think that we can delegate this to an LPN? No? Okay, so we don't want to go with that one, it seems like. Performing wound care on a stable patient with a chronic wound. Do you guys think an LPN can do this? Yes, looks like everyone's saying yes. Okay, let's check that off for now. Educating a patient about self-administration of insulin. What are we thinking? No? Okay. Monitoring a patient's vital signs and reporting changes to the RN. What are you guys thinking? Yes, it looks like everyone's saying yes. Okay. Performing an initial assessment on a newly admitted patient. Seems like everyone's saying no for the most part. Okay, so we'll leave that off. And A, administering oral medications to a stable patient. Do we think the LPN can do this? Seems like everyone's saying yes. Okay, so let's go through everything. Let's start from F again. So starting an IV line for a patient requiring fluids. I would not go with this, so nice job. Why would we maybe not go with this one? Who is this typically performed by? Whose scope of practice? Oh, why can't I see? Yeah, the RN, exactly. So I wouldn't go with this because we're looking for LPN. Performing wound care on a stable patient with a chronic wound. Yeah, LPNs can perform wound care on a stable patient. That's fine. I would definitely go with that. D, educating a patient about self-administration of insulin. Do you think we're gonna go with this? No, we crossed it off. Good. Yeah, I wouldn't go with this one. Why might we not go with this one? This falls under patient education, right? So who's doing this or who's performing this? An RN, exactly. And then C, monitoring a patient's vital signs and reporting changes to the RN. Yes, I would go with that. LPNs can monitor vital signs and report any changes to the nurse. So that's fine. I would keep that. Nice job. Option B, performing an initial assessment on a newly admitted patient. No, I wouldn't go with this. Nice job. Why wouldn't we go with this one? Whose scope of practice is this within? An RN, not an LPN, exactly. Administer oral medications to a stable patient. Yes, I would go with this. Nice job, everyone. LPNs can give oral meds to stable patients. So that's totally fine. So I would go with A, C, and E. Nice job. Perfect. Awesome job, everyone.
Excellent job. So again, look, I know I spent a lot of time on cardio and I did EKG, CAD, heart failure. Nurse Brittany is teaching delegation, which is again ethics, delegation, things of that nature are again Med-Surg. It's probably one of the first topics that we actually learn about, right, Nurse Brittany? In Med-Surg is actually one of the first topics that we actually learn about is ethics and responsibility and things of that nature. So do you think we can squeeze in one more for everyone?
Yeah.
I think why not? Let's do it. Let's do it.
Let's do it.
Squeeze in one more.
Okay, so let's see. So we have another select all, another delegation question. So let's see. Which of the following tasks are appropriate for the UAP to perform? So what can the UAP do here? An RN on a busy medical surgical unit is planning care for the upcoming shift. The RN delegates tasks to the UAP. Which of the following tasks are appropriate for the UAP to perform? And we have a select all. So what can the UAP do here? So let's start with the last option. So F, performing blood glucose monitoring on a stable diabetic patient. Do we think yes or no? Can the UAP do this? Yes. Okay, so let's check it off for now. E, providing post-mortem care to a deceased patient. Can a UAP do this? Yes. Okay, so let's check that off. Measuring and recording a patient's urine output. What do we think? Can a UAP do this? Seems like everyone's saying yes also. Okay. Feeding a patient with dysphagia who requires aspiration precautions. Seems like everyone's saying no here. Okay. Changing a sterile dressing on a surgical wound. Yes or no? Everyone's saying no, so let's get rid of that. And A, assisting a patient with ambulation. Can a UAP do this? Everyone's saying yes. Okay, so let's go through all of them again. So performing blood glucose monitoring on a stable diabetic patient. Yes, I would go with this. UAPs can perform blood glucose monitoring on stable patients, although it depends on the facility's policies. But yes, I would go with this. That's good. Providing post-mortem care to a deceased patient. Yeah, UAPs can perform most post-mortem care, so that's fine. I would definitely keep that in. D, measuring and recording a patient's urine output. Yes, I would go with this one. Nice job, everyone. Yeah, UAPs can measure and record urine output, so definitely that's within their scope of practice. C, feeding a patient with dysphagia who requires aspiration precautions. Who would this fall under? The RN or the LPN, but not a UAP. They would not know what to do if anything were to happen. So I wouldn't go with this one. Nice job. Changing a sterile dressing on a surgical wound. I wouldn't go with this one. Why wouldn't we go with this one? This is going to require sterile technique, right? It's also going to require assessment. So who can do this? RN or LPN, awesome, but not a UAP. Exactly, not with sterile technique. Option A, assisting a patient with ambulation. Yeah, definitely. UAPs can assist patients with ambulation. That's totally fine. So awesome job. Again, you guys got both of them right on point. Nice job, everyone.
Excellent, excellent job. And thank you, Nurse Brittany, for doing that.
Of course.
So with that said, I do want to take the time to thank everyone for joining us today. We did cap out at 500 people again. I hope you guys enjoyed Med-Surg and understand that Med-Surg is something that we actually teach throughout the course. We just do it system by system. So don't be intimidated when you hear the word Med-Surg. People just kind of freak out about it. With that said, if we did anything to offend anybody, we apologize. If we can get better, please let us know. All we ask in return is just spread the word about us. Spread the word, spread the word, spread the word. We love doing this for y'all. The more you spread the word, the more we can do it for y'all. But you already know what I want to do right now.